Hi, this is Matthias Friedrich for CVI Plus, and with me tonight is Dr. Andrew Powell, Director of Cardiac MR at Boston Children's Hospital, and you're one of the world experts in CMR of congenital heart disease. Any highlights of today? Anything you found very interesting here at the SCMR 2013?
Well, we had two sessions today specifically devoted to congenital heart disease and pediatric heart disease. The first one earlier today was a case session, and the cases were picked to highlight some controversial issues in imaging and congenital heart disease. For example, there was essentially a back and forth debate about 3 Tesla scanning and whether that's the best choice versus 1.5 Tesla for imaging young patients and patients with congenital heart disease.
Are there specific advantages and disadvantages to 3T with respect to children, and what are they?
I think one of the main attractions of 3 Tesla scanning, at least theoretically in pediatrics, is, as you would imagine, all the heart and blood vessel structures are smaller. And so the purported advantage of having better signal to noise should allow us to get better spatial resolution without getting grainy images. And so that's very appealing to us, particularly when we're trying to image the 0 to 2 or 3-year-old patients.
Yeah. So what was the verdict? Do you hope for 3T then?
I think there was no clear verdict. Both participants, the pro and the con, did a very nice job highlighting the issues, and I think, as often happens in these discussions and debates, there was a fair bit of convergence at the end in that when 3T works, it gives very nice images, but it needs to be more consistent and reliable from patient to patient.
And what's your next scanner, 3T or 1.5?
I'm on a 1.5 Tesla now, and if I could only have 1 Tesla, I guess I would still stick with, if I could only have one scanner, I would still stick with a 1.5 Tesla, at least for the next year or two, until some of those technical issues were sorted out a little bit more.
And anything else exciting going on in the field of congenital CMR?
Well, the second session today was an abstract session, again focusing on pediatric and congenital heart disease. And there were 6 abstracts discussed, and all the presenters did a fantastic job. There was one presentation by Dr. Hart from the University of Kiel, in which he used 4D flow mapping to examine patients with a Fontan circulation.
Is the 4D opportunity, I guess it's a huge thing for pediatric CMR, isn't it?
It is, and what was interesting about his study is some of the listeners may know, in a Fontan circulation, there's no right heart pump. So all the systemic venous return drains passively directly into the pulmonary arteries. And what they did was something very interesting. Typically, when patients have used 4D flow, they've gated the acquisition to the cardiac cycle. So, and when you do that, these are relatively long acquisitions. So it's done over multiple respiratory cycles. So all the variation with respiration that might occur is averaged out, since you're basically just gating to the heart cycle, and some of your data is acquired in inspiration, some in expiration, and that respiratory effect is basically blurred out or averaged out. What this group did is they did that standard gated approach, and then they did something called respiratory gating, where they didn't gate to the cardiac cycle, but they acquired data at strict intervals across the respiratory cycle. So what you did is you averaged out cardiac motion, so what you were left with was variations related to inspiration and expiration.
Oh, that sounds interesting. Yeah. And the last question, where do you see very interesting near future developments? And I'm thinking about all the mapping stuff. Is there something interesting for congenital and pediatric CMR? The advent of compressed sensing or transmit-receive technology with the potential of much higher SNR. What are the most exciting things you see ahead of us in congenital MR?
Well, I think there's a number of things. We're looking to adapt some of the techniques that have been currently being applied and investigated in more adult-based diseases such as T1 mapping, and so we're interested in seeing what that can tell us about the pathophysiology of pediatric heart disease. I At the same time, we're looking for faster, easier examination techniques, particularly for the younger patients that can't really be in the scanner for 30, 45 minutes at a time and still be able to cooperate with the examination. So really we're interested in improvements on both the research end in terms of breakthroughs in techniques, but we're also interested in practical things to help us with everyday throughput.
Yeah. And maybe a last additional question. What's your relationship with CT? So CMR versus CT, where is this going?
Well, that's a difficult question. I think, again, taking the pediatric perspective on this, we know that children are more sensitive to the effects of ionizing radiation and the cancer-causing effects of that. So I think the answer is, for me at least, that there is a role for that. It just has to be used very judiciously. I've personally been pleased to see that the dosages for CT examinations have steadily declined over the past 6 or 7 years. So clearly that's evidence that people are paying attention to that. And in the end, these decisions have to be based on individual patient indications as well as the local expertise and resources available.
Okay. Thank you very much, Andrew. This was very interesting.
Very nice. I've enjoyed it.
This was